Hello to all of our quality-minded listeners, and I would like to give a special shout out to our Mayo Clinic Care Network members. Welcome to Key Into Quality, a Mayo Clinic podcast focusing on healthcare quality trends and solutions. Today, we're exploring patient experience, a concept that goes beyond satisfaction surveys to encompass every interaction a patient has with the healthcare system. From communication with providers to ease of access, emotional support, and even the physical environment, patient experience shapes not only how somebody feels about their care, but also, as it turns out, how effective it is. So thank you for joining us. I'm Dr. Tim Morgenthaler, a professor of medicine here at Mayo Clinic and a vice chair of Mayo Clinic Quality. Co-hosting with me today is Sheri Nemec. Sheri?
Hi, everyone. I'm Sheri Nemec, Consultation Relationship Manager for Quality at Mayo Clinic. And Dr. Morgenthaler, I'm excited for this conversation
This
today.
is really your thing.
It is.
Yes, you have all of the patient experience roots. I'll bet some of our listeners are wondering, how does patient experience actually relate to quality? Of course, the Institute of Medicine long ago, when they talked about the 6 different metrics for quality, they did name patient experience as one of the important ones. And that's because research shows that a positive patient experience isn't just a nice thing to have, it's actually linked to better health outcomes, better safety, more trust in the healthcare system, and better follow through with health recommendations. So, in other words, when the experience improves, the quality improves. To unpack this a lot further, we're in for a real treat today. We're joined by a longtime quality friend and colleague, Dr. Sunanda Kane. She's currently Mayo Clinic's Chief Patient Experience Officer, and she's going to share insights on what makes a great patient experience, how Mayo Clinic approaches this vital aspect of care, and what healthcare leaders can learn from it. So let's get started. And I'm first just going to ask my friend and colleague, Dr. Susie Kane, tell us about yourself. Tell us how you ended up here and kind of things that you do clinically and for the institution.
Well, thank you so much for having me. This is really an honor, and this is going to be fun because this is how I spend my day. So I am a professor of medicine in the Division of Gastroenterology and Hepatology here in Rochester. And for those listeners, you may or may not know that our GI division has been ranked #1 by US News and World Report for 34 years running. So we're obviously doing something right. And just yesterday, Newsweek again said that Mayo Clinic Hospital in Rochester was #1 in the world. So again, we're obviously doing something right as an institution. So, but heavy is the crown, right? So we have to not rest on our laurels, but continue to think about how we give exceptional care. And what does that look like as society and culture changes, we have to change with it. So it's very interesting that my pathway towards this ultimate role, which I'm very excited to have, started with my research career, which was looking at patient adherence. It used to be called compliance, but compliance sort of takes on a dirty connotation, and it's more about adherence. So within GI, I was interested in looking at patient adherence with medications and recommendations for surveillance colonoscopies in the area of inflammatory bowel diseases, which is my area of clinical expertise. And so back then, which was in the late 90s through the 2000s, tried to understand patients' philosophies, their psychology, their behaviors as to why was it that they were not taking their therapies, because we could prove that if you don't take your medicine, you're going to have disease activity. And that seems like a no duh, but we really had to show it. And we had to understand why patients weren't, quote unquote, behaving the way we wanted them to. And it led to poor outcomes. And so I think through that research profile and experience, led me then, when I moved to Mayo Clinic, gave me the opportunity to be at the #1 site for GI care. And then I ended up being the associate clinical practice chair for a few years. So I could really delve into how do we change our practice in order to help patients have better outcomes. And then I joined the Quality Academy and started understanding more about how quality methodology could help. And then within GI, I became the associate chair for patient satisfaction and experience. Because again, understanding that patients do have issues, that some of them are actionable, and that we've changed the way that we see patients and interact with patients based on their feedback. And because we are such a large division, and because of all that work, then it became a natural sort of progression to then be fortunate enough to be able to do this for the entire enterprise.
I'm just going to point something out for our listeners because they don't know all your background. Dr. Kane really truly is an expert clinically. She has over 300 peer-reviewed publications in the areas of the technical and medical aspects of managing inflammatory bowel disease and gastroenterology in general. But I think what you just saw in her answer is that behind all that technical and clinical expertise is someone whose heart just yearns to learn and move people and organizations to do better. So we're just really lucky to have you here.
We are super fortunate. I agree.
I forgot to mention that along the way that I was the president of the American College of Gastroenterology, the premier clinicians society for gastroenterology. And during that year, also was able to add a couple of new committees to the college. And the year before that, I was the chair of the brand new quality committee of the American College. So I not only talk the talk, I walk the walk.
Awesome.
So now we're going to dig in a little bit on the patient experience. And I'm going to ask a question that I know you get asked a lot, but you'd be disappointed if somebody didn't ask.
Right.
What does patient experience even mean?
Well, I think you set it up brilliantly with the introduction, which was patients have an experience when they come to get healthcare. And that experience is a journey, it's a pathway. It starts when they either pick up the phone to make that appointment or log on to the computer to make the appointment, or however it is that they make the appointment, or that even when they get onto the Mayo Clinic website because they just got diagnosed with Crohn's disease and they're frightened out of their minds, and that they want to get information and consultation from the best GI division in the world. So what does that look like? So they start with that first connection. So that person who is taking their call, are they warm? Are they understanding? Are they helpful to making sure that that patient gets to the right provider in the right amount of time? And then there's wayfinding. Can you make it here to Mayo Clinic? You know, if you are more than 50 miles outside of Rochester or 50 miles outside of Phoenix, Arizona, Scottsdale, Arizona, how do you get to that destination? Or if you are a community patient and you are a farmer in Mankato and it's a 10-minute drive over to the Mankato facility, how is it that you're going to get there? Is there public transportation? Are you going to drive? If you get there, where are you going to park? Is there a valet service? How long from the parking lot does it take you to get into the main building, into the clinic that you need? If you come into the main building, are you greeted warmly? And that if you need a washroom right away, is there one available to you? What does it look like? Is the lobby clean? Can you get an elevator quickly? When you come to the right clinic, is it a kiosk or is it a person who is checking you in? How long is your wait time? Have you been told that the doctor or the provider is running behind and that we're sorry, it's going to be another 20 minutes? I could go on, right? But that's what experience is. It's not just, you know, the interaction with your provider. It is all of those things that lend to what happens during that encounter.
So compare and contrast patient satisfaction, because you said in the distant past you were in charge of patient satisfaction. Patient satisfaction, patient experience. Help us out.
Right. And so a lot of people are confused about patient experience, and that people think that patient experience is grievances, complaints, and compliments. And it's not just that. It's how does the patient feel at every part of their journey? And every patient has an experience. They may not be satisfied with the outcome, but they may be satisfied with the experience, or at least are reflective of the experience that they had was one that they would recommend to their loved ones and their friends.
Still sticking in here to help delineate these things. For at least 2 decades, everybody's been dealing with an acronym called HCAHPS, where
Yes.
the federal government decided they're going to try to get a peek under the hood at the patient experience in the hospital. And I think HCAHPS has experience as its goal. Is that patient experience, or is it satisfaction, or how would you make us think bigger?
So HCAHPS tries to peek under the hood for experience, and people have over time equated that with satisfaction. But experience has to do with safety as well. It has to do with quality of care. So if you cannot get a good night's sleep, is it because there is construction going on around? Is it because you are sharing a room? Is it because the pumps are all failing and that the equipment is faulty? Is it that the patients felt like there was communication between their healthcare providers and them? So they're asking about teamwork and what they're observing, as well as interactions with you as the patient. So it is about experience, but it equates ultimately to safety and also satisfaction.
Yeah, I think over the last even 10 to 15 years, there's been so much change in how the healthcare industry thinks about patient experience. What are some of the things that you're seeing in the industry? What are we moving towards in this space? Any thoughts about that and challenges we're experiencing along the way?
We could have a whole podcast just on
True.
challenges, right? But I would say that one of the biggest impacting factors as we move into the future is AI. What does digital health look like? So during COVID, we had to pivot literally within days to providing care that was more virtual and digital than in person. Okay, so digital health, but we found that that was very satisfactory and that we could provide continued good healthcare to folks that didn't necessarily need a physical exam. So telehealth is here to stay. What does that look like in terms of other ways that we can maximize a patient's experience and optimize care and try to help with the offloading of the crunch in the hospitals? So patients who can get their after hospital discharge, if they still need visits, can that be within their home? Can they get their cancer care at home? Can they have monitoring of their vital signs at home with wearable technology? Can we, monitor people that way? And then with digital health comes the care that we give via the portal and the MyChart, and that it's a good tool. I don't think that we use it optimally because patients will at 2 a.m. send a message via the portal that they're having a fever of 103 and vomiting. That is not appropriate, but it is a nice venue for quick questions and follow up with the healthcare team when somebody's been started on a new medication, when they've discontinued a medication, and just simple things like that. And then not just digital health, but then AI. And where can we use AI to help us provide better care? Not replace care, but help us as a tool. So, what does AI look like? It helps us with triaging patients. It helps us with predicting patient factors that may lead to a worse outcome so that we can be proactive. It helps us with ambient listening so that we can, instead of being tied to our computers, actually look at the patient if we know that AI is helping us with recording and building clinic notes. In those ways, AI is amazing and is a great tool. Again, the use of chat bots and responses, we still have to figure out how a computer can help us respond to patients as opposed to building us a template with which then we fill in the gaps and try to make those responses and those interactions warm. And again, I'm going to come back to this 4-letter word a lot, which is warm. Patients build loyalty and trust when there is warmth and competence. A lot of people can be competent, they can be trained, they can be educated and be competent at their job, but it's really the warmth that we add to that. So somebody can park your car, but if they smile at you, if they interact with you, then you're going to have a better experience with that valet parker at the beginning of your journey. People come to us afraid and hopeful. And fear is the negative driver and hope is the positive driver. So what we can do to minimize fear, and how is that? Well, it's with looking at the patient directly in the eyes. It is giving them a smile, asking if they need some help with directions. Can I show you where the elevator is? Those are the things that are going to help waylay fear. And when you meet with patients, the providers are the ones who can provide hope. Yes, you have a complex and serious condition, but we've seen this before, we have experience in it, and we're going to help you get through this.
One thing I want to go back to for a moment, because you've raised so many good points. We asked about what do you think have been the biggest challenges recently? You pretty quickly focused in on, wow, we went from being a face-to-face practicing organization to being one that's heavily involved in various virtual or telehealth interfaces and digital interfaces. So maybe just for our listeners, there certainly is a set of skills that can be learned and refined and improved. So as we think about virtual interactions, what have you learned are like 3 don'ts and 3 do's?
Thank you for keeping me honest. We have a goal of trying to meet the patient's needs, and sometimes that is not with virtual care. So it is still with a face-to-face in-person visit. So we are not looking to change our care to be 100% or even that the majority of our care is virtual, but that in the right scenario, it is helpful. So 3 things that you do in a virtual visit is that you make sure that you understand where they are. Are they in their home? Are they in their office? Are they in their car that hopefully is parked? That you want to know who else is in the room. They may not be on camera, but maybe they're off to the side, and that you want to make sure that you are still including anybody else who is there. And that you just remind the patient how much time you have so that you can actually get to the agenda for the visit. And most of the time, I let the patient drive what the agenda is going to be. 3 don'ts. Don't assume that the patient is in a place that they can freely talk. So they may be at work and they just pulled over into a corner to have this call. That there may be somebody in the background who is listening and interacting as well, and that the patient doesn't feel comfortable or free to be able to have a conversation as if they were in person and you asked the loved one to leave the room, so that it was just one-on-one. And number 3, that a virtual visit replaces the ability to touch someone, to hug someone, to hold their hand while they are having that experience with you.
Dr. Kane, you mentioned a few things I know that Mayo Clinic is focusing on, those concepts of warmth and competency, building trust through human connection and relationships. Anything else more you want to say about that, or where are you envisioning that we're going in the experience work from here?
It's really interesting. And again, Dr. Morgenthaler, you talked about what does the actual environment look like. So when you talk about warm and competent, somebody who comes into a building and sees that there are signs everywhere that are just very confusing and that they still are just as lost, even though they're looking at a direction board. That's not warm.
Not very competent either.
And not very competent either. Working with our sign committees, working with our environmental and general services as well, working with different committees that don't have direct, you wouldn't think about direct patient care, are opportunities where we can grow in terms of looking warm and competent. That training, we are so lucky that we have such a robust training, education, and coaching team within patient experience, that their job is to help providers, leaders, managers be able to use scripting and teach them how to just change what they say or not to say, and use words that are more hopeful than negative and deliver the same message. So over time, I've watched nursing leaders have those training exercises, and it really makes a difference when you're in the hospital and on the floors and what that looks like. So being able to have the resources to offer how to talk to patients and build warmth, because everybody at Mayo is competent, but they may not understand how to increase their ability to connect with that patient. And it doesn't have to be a hug or warm and fuzzy necessarily. It just has to be that you are patient focused, and it can be as easy as looking them in the eye. And it's interesting that we got some patient feedback and said, I was so impressed because the provider knocked before they came in the room. And I'm like, well, that's experience 101, that
Right.
you respect the patient by knocking on the door before entering their exam room. So patients remember the little things. Maya Angelou, it's a quote that I use a lot. I'm paraphrasing Maya Angelou. The patient may not remember what you said, they may not remember what you did, but they will remember how you made them feel.
We're probably going to have you come back because we're starting to run short on time and there's so much here.
Oh, no, really? We haven't even talked about provider burnout yet.
Hey, let's make that another topic.
Well, I think we should because one of the things that I really saw over the past years is we started out with satisfaction and then we went to patient experience. And boy, howdy, in the last 5 or more years, we all of a sudden came to the realization, hey, wait a second, it's actually about the Mayo Clinic experience for everyone. It's like, how are we all in this together?
Exactly. And we haven't talked about staff safety and workplace violence.
So here's the thing, we got to close today. We'll have you back. So thank you so much. But I want to ask, you've talked a lot about your journey in patient experience, and I know you've worked in safety and quality and all these things. Let's say you were talking to an organization or a person out there in an organization that has a heart like you do for improving the patient experience in their organization. What would you tell them about how to start?
So first of all, listen to your patients. They are the font of information, and they will point out things that you never noticed. You come to work every day and you never noticed that there was a sign on the door that was just taped up there. And it's just become part of your reality, but it looks bad to the patient. That they will tell you that the food is bad. They will tell you that it's a long walk from the laboratory facilities to the clinic. So number one, make sure that you are looking at whatever surveys you're using that are mandated and regulatory by the government, that you are actually looking at the data that is in those surveys. And then hold your leadership accountable for understanding and looking for the opportunities to change things. And then also make sure that you are holding your leadership accountable for the health of the workforce, because if you don't have a workforce that is happy and feels safe, they are not going to be able to give good care to patients, and those patients are going to know and feel not well cared for. It's a circle that is all interconnected.
Wow, Dr. Kane, this has been really fun. We are committed to having you come back and finishing some more about this. But for today, we have come to the end of our podcast. I'd rather leave our listeners wanting more. And we're so glad that you could join us. We're grateful to you for really sharing your heart about this and your experience, and also for the things that you do for Mayo Clinic and for our practices. So we're really glad that you could come join us.
Well, thank you for having me, and thank you for paying attention and understanding how important this really is. I'm very much appreciative of the time to share today. Thank you.
Fantastic. So for our listeners, again, Mayo Clinic's Key into Quality podcast aims to highlight some first steps in addressing some of the most important quality challenges you face in your organization. Our goal is to improve quality for patients and the populations that we all serve. If you enjoyed this podcast, we'd be grateful if you left us a review on Apple Podcasts, a rating on Spotify, or feedback wherever you listen. You can also follow us on your favorite podcast platform. Let others in your organization know about the podcast so that information can be spread and new conversations can take place. Until next time, goodbye.